background there. Okay, so we are the SEOW meeting. Up here's my agenda. Okay, so SEOW meeting for Tuesday, May 7th. Time is 9 o'clock. For SEOW, we have, let's see, Tom is online, and is Robert? I'm looking for Robert. Do I hear a Robert? No, no Robert, but Sue is here. So, so we have 3 of us out of 4, so we're still a go. Looking at the meeting synopsis for April, any comments from anybody? Get rid of this window. Okay.
Move to approve.
Okay. Tom moves. Sue, you want to second that? Oh, you're on mute.
I gotta find my mic. Yes,
Sure.
I'll second that. Thank you.
Okay, motion and second to
Medium
approve
roast.
last month's meeting minutes. All in favor, say aye. Aye.
Aye.
Okay, approved. That takes us up. Now we're back to ahead of schedule. All right, so we're looking at now discussion of the summer research groups that are being proposed by the leadership. There's Robert. Robert, nice to have you online. We just approved the minutes with the votes, so that's where we're at. So looking at summer research groups, we've been discussing this in the leadership team to see what we might be doing this summer for our research areas. And we have some proposals and like to review them with you. And that is going to go over to Mercer, I think. I'm sliding down my.
It is Bill.
Here.
This
Okay.
is Christy.
Yep. Take it away.
Wonderful. Thank you. Just waiting for my slides. Good morning, everybody. All right. So I get to dive into our OEB and PEB summer research groups. And so first, I'm going to step back and just talk about our summer research groups and historically what we've done. So if we can move to the next slide. Next one there, and one more. Thank you so much. And so our summer research groups have been a great way to look at emerging trends. In 2023, the research groups focused on doula services and GLP-1 drugs. And these groups were established to, and they included board members from PEB and OEB, along with our carrier partners, OHA staff, and Mercer team. They met twice per month as each of these groups met, and then also a leadership team was created to provide guidance once a month to each of the research groups, really to align with goals, making sure that the groups were on the right track, and then also to give guidance as we move towards making recommendations to the board in the fall. Really last summer's research group in doulas and GLP-1 showed really good success with collaboration amongst board members and carrier partners, and really had some great benefits of shared efficiencies and combined brain power. And so, we really would like to continue this momentum and, shared thinking going forward into 2024. And the proposed topic for our 2024 research group is traditional health workers. Traditional health workers, this topic really came from conversations around providers and care gaps, particularly in rural areas, but also other places across Oregon, and as a possible way to kind of support the workforce and help close gaps in, members kind of getting the care they need, maybe feeling comfortable in accessing care or knowing what's out there. Traditional health workers were recently added to Oregon Medicaid provider networks. And as you remember maybe from last year, that doulas actually fall under the traditional health worker umbrella with Oregon Health Authority and are in that traditional health worker registry. So our summer research group would really focus on topics and questions that we have around traditional health workers, really diving into them and learning more and seeing what kind of impact they could have for OEB and PEB members. And I'll go into this a little bit detailed to show kind of what we know thus far about some traditional health workers that are being integrated into our communities. So if we move to the next slide, the other thing is just recognizing these summer research groups really do align perfectly with our OEB and PEB goals. They really show, shifting left, can have some affordability, quality, and efficiency for sure. And then also can help in communication and, again, bridging gaps to care, getting people connected to the care that's right for them, and offering culturally and linguistically appropriate services. Moving on to the next slide, again, it just shows how they align really well with PEB goals as well, which is why it makes so much sense to have this be a collaborative effort in these research groups. Next slide, please. And one more. All right, so I'm going to just share a little bit about what we know thus far about traditional health workers. And we're just kind of scraping the surface at this point. But as I shared, really, they are trusted individuals in the local communities with, they're members of the local communities of which they serve, oftentimes have socioeconomic ties and some type of life experience that is similar to those in the communities. And they oftentimes are providing person and community-centered care, and again, bridging gaps, and really integrating, though, within either the health system or the clinics within that community to connect members to care. One thing we found just in our initial dive here is that from the Oregon Community Health Workers Association, and so a community health worker is one type of traditional health worker. Some of the benefits that could possibly impact PEB and OEB members is they're seeing improved health outcomes, reduced disparities, improved access to care, and reduced costs. So again, all great alignments to our PEB and OEB goals. If we move on to the next slide, please. So as I said, there's 5 types of traditional health workers. We're still, and this is part of what the summer work group would do, is really learning more about these different types of traditional health workers, understanding what the impacts are that they're making right now, and then again, understanding what kind of impact they might be able to have on PEB and OEB members as they're more integrated. So there's a community health worker working in public health. Again, they are working alongside or within the clinics that are in that community or within community-based organizations. They are providing guidance, peer counseling, helping with health education, and may even provide some type of direct services, whether it's just general first aid or blood pressure screenings and some of those pieces, those preventative screenings. There's also a peer support specialist, so more along somebody who definitely has that lived experience and able to, kind of meet a member where they're at and really have empathy and relate to what that member might be experiencing. These are in a couple different areas. We see family support specialists, youth support specialists, recovery peers, and mental health peers. We do know that one of our carriers has been doing some creative work with the mental health peers and recovery peers as a way to help connect members and communities to mental health resources and programs. So it's exciting to kind of look forward and be able to learn more about how this could impact PEB and OEB members. If we move to the next slide. The next 2 that we would really be diving into would be a peer wellness specialist. So somebody who's really helping outreach and might, again, be helping with assessments for mental health and substance use disorder services, helping somebody connect to care, finding the right program or the right area for them to get the help that they need from. Providing education and information about those resources, and then even helping with maintaining recovery, being, again, that peer support person that can really help guide that person and offer support. And then lastly, there's the personal health navigator. So this is really helping somebody guide them, support to finding the support they need, and also within healthcare decisions, depending on that person's circumstances and their needs. And again, all of this being really delivered with culturally and linguistically specific care with meeting the member's needs. And then, as you see, the last one on here is birth doulas, which we had incorporated last year, and both boards approved. Tom?
Yeah, so my question from our discussion at the last board meeting had to do with lay midwives, and I thought that we had asked that to be looked at over the summer also. I'd have to go back to look at the details of it, but I wonder if lay midwives fall into this category also, or at least we could maybe have, if there's time, to have that issue looked at also.
Yeah, thank you, Tom. And I'm sorry, I'm looking through my notes here because I do have I did do a deep dive into midwives and what the coverage is. And I believe, and I'm sorry, I'm not going to be able to recollect it all correctly off the top of my head right now, but yes, thank you. We will follow up on that. We did do a deeper dive, and I think there is an oversight through OHA of midwives currently. MODA does cover professional midwives, and there is an extensive curriculum and certification in order for them to get that professional midwives, certification through OHA. It just became, there's some complicated pieces to it. So yes, let me put that on our takeaways and we can bring it back to SEOW.
Thank you.
Yeah, you're welcome. I guess any other questions at this time about the different types of traditional health workers? Obviously, I know we don't know a whole lot right now, and that's what our summer work group would be diving into. All right, let's move on to the next slide. So just high level, wanted to share, that traditional health workers do have training and certification requirements. It is, again, under Oregon Health Authority and the Traditional Health Workers Registry. Once a traditional health worker does the requirements, they can be registered and obtain their own NPI, which is the kind of the mechanism for billing. To be certified as a traditional health worker, as I said, there are different types of required trainings that are authority approved programs. There are application requirements, a process that has to be gone through in order for them to really be accepted to the state registry. And then there are continuing education requirements, which can vary by those different types of traditional health workers. And we just put a note here, obviously, that birth doulas had also a much more extensive certification and training process in place as well. Moving on to the next slide. So we know, in the summer that one of the first things would be to really look at what currently is being covered. And so we did a very initial outreach to our carrier partners to find out. So Kaiser currently does have traditional health workers in their network and does cover them from OAB and PEB plans. We, however, do not know exactly what impact is happening, which areas of Oregon are these are traditional health workers, and can we do more to incorporate them into the care that PEB and OAB members are receiving? MODA does have also traditional health workers for their CCOs, but does not currently have coverage for PEB and OAB plans. There are some PEB and OAB members that might be having contacts with traditional health workers just based on the clinics that they're part of and they're members of. But again, we're not sure of what the impact is or exactly what those areas are. And then lastly, Providence currently does not cover traditional health workers in OAB and PEB plans. And we're not sure whether they're part of their network in other places or with their CCOs. So again, more questions and things for us to do a deeper dive into over the summer. As we move to the next slide, I think maybe two more. Yeah, right here. Great, thank you. And so these are just some top of mind questions that that we wanted to share that came up. And I'm sure you all are having lots of questions also right now come up for you. But there are, again, what is the impact that traditional health workers are making today? What does the state scope of practice include? What are some of the lessons that we can learn from how traditional health workers are right now being integrated into Oregon Medicaid? We know we did this with the doula benefits, and we really learned a lot by talking with one of their analysts in the traditional health workers program. We've done a deep dive with one of our carrier partners to hear also what they're doing right now. So I think really learning from what's currently been done. And then from there, we would really look and see what the impact could be for PEB and OEB members. What areas and roles would they fill? And then what opportunities would there might be for workforce investments? I know one of the questions that comes up often is, and this came up with doulas, is the impact of covering traditional health workers from OEB and PEB members going to be beneficial for the traditional health workers workforce? Is there impacts that can be made or things that can be done in order to increase opportunities in this workforce? What does reimbursement look like? Again, wanting to see what the reimbursement model is, making sure that it's equitable. How does a traditional health worker get reimbursed when they're part of a community or a clinical team? And then, are there any redundancies in services that are already being offered by the plans? So just a few questions that we have. Obviously, a lot more would come. We met with one of our carrier partners last week, and I could probably have a list of about 35 questions that came to mind for me. So lots of exploring for our work groups to do. And again, the importance of our research work groups was also to always have at the end of the time is to have an action or some type of impact that would be made for PEB and OEB members. I think that might be the end of my, if we can go one more slide, are we at the end? Okay, so next steps. One more slide, thank you. So our next steps would be, I guess, first of all, I'd love to hear if there's any feedback or, just making sure that this is the direction that the SEOW group would like to go and the recommendations to the board. If so, then we would make participants would be identified for the summer research work group. We would have those bi-monthly meetings scheduled from June to August. Again, researching this topic. And then our plan would be to, report out the findings to the OEB and PEB boards in September. So I will pause there. Any questions, or Bill?
Let's open the floor up to comments. Personally, I'm for this. I think there's always been a request for these kind of coverage from a group of or from a collection of our membership, and then the MODA side not covered. I think it brings positive impact from what little data I've seen, but I want to make that a further deep dive. So this to me has a lot of interest.
I agree. We have our goals, our processes with SEOW, which have to do with, looking for evidence to support decisions, but we also need to get outside of in a way, the medical establishment, because there are other types of support that our members can receive. And I think the doula, it was a great example of that, where we thought outside the box, and I think that it's going to be something that will improve service and help outcomes. So we'll see. That's one that we've already authorized, but looking at that entire realm, I think, is very, very appropriate, but still holding to our principles of looking for, a cost, quality, and service that, kind of drive the triple aim that is the foundation for both OEB and PEB.
Yeah, I would echo both commenters, and when we think about our strategic plan in shifting left, certainly getting access to care, potentially at an earlier and lower level or supportive manner, is certainly worthy of a deeper dive. So 2 thumbs up from here.
Andrea, Greg, Robert, any comments? You thumbs up?
I'm all about researching innovation, so it sounds like a good topic.
Yeah, I'm very interested, especially for help in rural communities.
All right, Greg, I saw you shaking your head, so that's a good thing.
Yes.
All right, I think this is a good topic then for let's make a recommendation. Everybody good with making this our summer research group? We'll staff it and get membership for it. I think everybody's had a positive comment, so we're a go on this. Right.
Bill, could I
Yep.
add one more comment?
Yep.
There is a parallel group to SEOW, the innovation work group, and the other thing that group has asked for research for during the summer is to build in a way the specifications, and we'll see it at the board meeting today. We're going to be talking about shifting some of the performance guarantees from just from administrative to move that area into behavioral health, because that's been such a important area and a challenge. So the other part that the plan will need to be doing, working with OHA staff from OEB and PEB, and our consultants will be building out specifications for measures that look at behavioral health, not so much from a clinical standpoint, but from an availability access standpoint. So that's the other that'll be the other summer project that people need to participate in.
Are you seeing a collaboration between those two projects? Or
I don't necessarily think that there's an off the get-go, they're not. I just wanted to,
okay, just mention it.
To mention it so that SEOW sees, knows what's happening also in this other aspect of using the summer months. Now, PEB is year round. They don't take the time off, and the board doesn't take time off during the summer. But that's another area of innovation and change that we'll be seeing an additional summer work. What's going to be interesting will be if we do build out more involvement with traditional health workers. What you saw in Christie's presentation was maybe half of it seemed to have both support for mental health issues and for substance abuse disorders. So it'll be, once we understand where that traditional health worker fits, it'll be interesting to see it kind of flow into what we're talking about in terms of behavioral health networks and access.
Christy, what do you see as the recommendation for the size of this work group? Did we talk about that and I missed it?
I don't think we've had that conversation. So I'm not sure if it's maybe, I think, again, given some of the new board members within OEB, I think I would defer to all of you to feel like what is the best mix. I think if we had 2 board members from OEB and 2 from PEB, that would be fabulous.
That's where
I don't know if that's okay.
That's where my mind is at. If we can get 2 from each board and 2 staff members. Go ahead.
No, sorry, I didn't mean to interrupt, Bill.
Yeah.
Is actually, we need to limit it to one board member for this work group, one board member from PEB, one board member for OAB due to the public meetings law.
Oh, really?
Yeah.
This is a OEB. This is an OEB. What do we have? Like 9 members, so we can't have 4. Or I'm confused.
Well, it's actually, they just changed the law, and to be really kind of safe on this, I would keep it at 1 and 1, just like we did before. We had one board member from PEB and one board member for OEB when we did, say, the GLP-1.
Yeah, I was thinking because we had 3 groups running that last summer. Now
Yeah.
we just have one in the innovation group. So I mean, 2 is not even close to a quorum for our OEB board, anyways. Okay, well, I mean, I hear you. This just covers a lot of topics. That's why I was thinking 2 from OEB, right? This is a broader topic than doula or GLP-1, which is a very narrowed focused kind of data. This is more of a broader issue.
Well, and then when we bring the data to SEOW, which will then make the recommendations to the boards, that will give more opportunity for board members to really be involved in the actual recommendations that then go to the boards. So you can have as many, once it makes it to SEOW, you can have as many board members as you want, or who want to participate on that.
Okay, are we making the research group get-togethers public meeting or not?
No, they're not public meetings, which is why we need to be careful about that.
That's why I was asking, but still, you're saying it's not a quorum. Quorum is not the rule anymore. The rule has changed.
They said in the new law, which was, I believe it was 2805, and I'm blanking on the actual number, and they said if 2 board members got together and they could make a recommendation, that it had to be in public. Now, there's still more rules that needed to come out from the Office of Government Ethics. So there's still question about it, I guess is what I'm saying.
I was going to say, because that pretty much puts every city government in a violation of the law. I mean, as somebody who's on the League of Cities work, that's every city government would violate.
I mean,
that.
we can go back to the Department of Justice, or we can go to the Department of Justice
Yeah.
and get a final ruling if you want, and to
No,
see if it.
I'm trying to understand what you're saying from a broad perspective, not about this particular thing. There's a whole lot of government in violation right now, if that's the rule, right?
Well, like I said, this was just passed in 2013. Or, I keep going back, 2023, and there's still a lot of that needs to kind of flow down from the Office of Government Ethics, because they're now the ones who will be policing this.
Okay. So from this team on SEOW, there's only Robert and I currently on membership for this work group. I'm curious about this work group, but would defer to anybody on the OEB board that wants to step up. If that's not the case, then I'd be very interested in looking at this data over the summer. Robert, do you have a statement like that?
I'm fine with you doing it. I'd be happy to be a backup.
Okay. All right, so we'll check with the board this afternoon on membership and see what happens. Is that what we're doing, Glenn?
Yeah, I mean, I would, if you want, for a member to come at OEB, you might want to consider. We certainly can do from someone from SEOW, but we might want to consider, opening this up to the other board.
That's what I'm saying. But my point is that if nobody from OWEB wants to step up for this work, I'll do it. I'm
Okay,
happy to
gotcha.
do it. Right.
Gotcha.
So we'll have it. We'll have one no matter what.
Yes.
Right. So, okay. Any other questions about this topic? We are a half an hour ahead of schedule, so I'm going to suggest we skip the break and go right into healthcare innovations, unless somebody has an objection to that. All right, let's go for it.
Thank you, Bill. I hope it's because of your excitement that we're going to just jump right in.
This is one thing I've been talking about in the leadership team for those everybody else on the committee here, that we kind of look in a more forward perspective, and I am very excited. Is why I bring it up.
Well, good. I'm looking forward to it. I hope I don't disappoint. So the next section is around innovation in healthcare, and myself and Sarah will kind of help lead, and we appreciate the opportunity to lead and contribute to this section with the SEOW team here. Next slide. So we're going to start to explore the world of possibilities, right? But not all possibilities are possible. We're kind of broadening the boundaries for this discussion. And definitely we want to keep this interactive because it is part learning, but also kind of brainstorming and potentially some prioritization of further investigation and research. Just to give you a sense of the things that we're going to kind of dive into, because innovation is quite broad, but the ones that we've identified to target are around sort of personalized care and personalized treatment, including genetic testing, screening, and therapy. Other condition-specific approaches to care that are on the horizon. Digital healthcare is obviously a key part of it. And then the world of big data and real-world knowledge supported by machine learning and AI. So hopefully this is sort of plenty of food for us to sort of digest. And there's some rational reasons why we kind of are focusing on this for at least this part of the conversation. Next slide. So, we're going to build on the SEOW framework that we kind of presented last summer that helped us prioritize the SEOW agenda for our 23 to 24. And what we added and built out further is illustrated here in the scope section. So just to kind of reorient ourselves and level set, last year we kind of framed the 5 key pillars for the SEOW work plan framework. It was around strategy, helping OWEB board achieve its goals to provide, clinical leadership and guidance in terms of where to focus and what decisions need to be made at the OWEB board level. It was around advancement, exploring leading edge physical, mental health, and social benefits to ensure that what is available to OWEB membership is best in class, leading the sector. Around assessment, it was to be able to kind of dive into the current programs, looking for ways to ensure quality, efficiency, and value with a member-first, member-centric kind of a mindset always. And then the ability to look for opportunities, right? When we have access to data and we can approach it from a clinically based data-driven kind of a mindset and approach, how do we identify those opportunities to improve, to continuously advance what is in place forward? And then lastly, it is about accountability, not just the ability to measure, but then using those metrics to strategize on how we define the next level of performance, including setting performance targets. So the scope is kind of what we kind of built out, because through the year, we kind of heard different questions about kind of where each of these sectors, how far do we take it, and what's our role within that? So we kind of built out that scope as a frame to support the framework. So around strategy, I think the scope for the SEOW team is really to make recommendations that lead to decisions about renewal, termination, programs, and benefits through OWEB. When it comes to advancement and kind of what we're going to talk around here around innovation is to spend time and focus on emergency topics, emergency trends that may be impactful to the OWEB plan or it may be something that SEOW may make a purposeful recommendation to OEB to consider, to build on and add to the health benefit. The assessment, always trying to define ways that we can assess and quantify and show that we are, best practice in our evaluation, and that evaluation leads to effective engagement, solutions that matter to the membership, and the outcomes that we care about. With regards to opportunity, obviously, cost and utilization are key things that we have to manage. But then with that guidance of SEOW and understanding behind every cost and utilization are some of the clinical drivers, the things that are happening within our membership. How do we optimize that to improve ultimately the cost and utilization endpoints? And lastly, collaboration. The SEOW has, I think, great relationships. We collaborate often with our carrier and vendor partners. Ultimately, it's about delivering the best value and the best experience and solutions to our OEB members, and to influence and guide the OEB in those decisions. So hopefully this is a nice sort of placemat that frames the SEOW working plan. And like I said, the innovation is really going to dive into and support the second pillar today. Let me pause there and see if there's any questions or comments on this. That's kind of evolved over the 2 years, and hopefully this makes sense and kind of positions the SEOW work plan for this coming year favorably.
Comments from anybody? I've been staring at this for a couple months now, so I'm kind of in the groove.
Okay, always open to follow up and suggestions and feedback. Okay, let's go ahead and dive into. Yes.
Sorry, say again, Robert.
I think it's a fine structure. Yeah.
Thank you. Okay, let's kind of dive into the agenda for the innovation then. First slide, I wanted to share at least Mercer's kind of point of view and how we're envisioning or seeing the landscape, or the horizon as I'm calling it, circa 2030. And you'll see where we see the innovation happening categorically is in the following 3 areas. We're seeing evolving change around the context of care, right? We're moving and getting more comfortable that care doesn't always have to be within the 4 walls of a hospital institution or a doctor's office. It is really moving the notion of medical as well as health care beyond those formal venues. So yes, virtual care kind of naturally aligns to that, but there's other ways of thinking about how the context of care is really changing. The second trend that we're seeing is around more personalization. Personalization has 2 flavors. One is leveraging more individual data to care and making those care treatment choices. But it's also personalization in the sense that each individual, the patient, is taking a stronger role or ownership in terms of directing their own care. So it obviously, by definition, is more personalized to them, not just from a medical context, but also inclusive of their preferences and personal bias and views. And how does the healthcare system support that? Because unfortunately, it's always been somewhat paternalistic. As a physician, I would say it's always felt like what we say to our patients instead of a joint decision where the individual patient has a strong voice and influence into how those decisions get made. Thirdly, we're also seeing a trend towards more holistic approach and models of care. At one level, it is the collaboration and integration around understanding the impact of mental with physical. Again, the system has always somewhat separated the two as if they were operating independently from a clinical perspective, but we've realized that they truly do influence and impact each other. And if we're really focused on improving the individual's health and well-being, we have to move and improve on both the mental as well as the physical parameters of health. But it is also the patient journey and experience. How do we move the process of care from what seems like often a fragmented, disjointed process to truly being a more holistic, human-centered care process and journey? So some of the specific things are in the boxes kind of here highlighted. Many of the things have come up in our discussion, so I don't think it's anything new because many of these things are in flight. They're either piloting or being demonstrated, or in some places being somewhat broadly adopted, right? Especially around virtual care, virtual primary care, accessing physicians without having to make a physical face-to-face appointment. But other things like genomics and personalized genetic testing to guide not just the treatment, but upstream for screening and prevention is becoming more common. Next slide. I wanted to add sort of a third-party perspective on sort of healthcare innovation horizon. This one a little bit, the unit of measurement is slightly different, whereas the Mercer took sort of a look at the contextual system of care. This one gets into very specific innovation areas, right? So there's obviously a lot around digital transformation that's been happening for a while. So the blue arrows are kind of things that are somewhat stable and happening often enough in the healthcare ecosystems that it's kind of staying, right? So we've got everything from big data, 3D printing of tissue, nanotechnology, big data, Internet of Things. Some of the gray boxes are things that are sort of happening on the edge. Many are in the research realm. Some are in the pilot and early adopter realm. But we're seeing it happening, right? So there's already publishing research or case studies about these technologies. And some of these we'll go into. So, for example, the future of the omics. So omics are basically anything that we could measure. They can be genomics, proteomics, things that are biological, that are specific to individuals. So we have the ability to do more of those. When does it make sense? When does it bring value? Those are things to be figured out. Extended reality is another area that we'll go into today. Big data and digital transformation are the other two. So this is a nice sort of a roadmap of kind of things as they're moving forward in time. What will be determined is how many of these move truly beyond just pilots and demonstrations and become system-wide adoption, and for lack of a better term, a standard approach to care. Only time will tell, and we'll see how that moves forward. Okay, next slide. So let's dive in. The first one is going to be this sort of broad category I call personalization, because we're getting into very specific individual information and data, not sort of high level categorical, but down to the omics or the genetics information about the individual. Next slide. So from survey data, this one's from one of our vendor surveys in partnership with the American Cancer Society. Broadly around employer groups, we're seeing increasing progression towards higher interest around cancer screening, and specifically genetic screening, for two reasons. One, there's more visibility of that technology. There's more vendors knocking on people's doors and creating noise and visibility to that. But we also realize collectively, traditional cancer screening based on U.S. Preventative Task Force, we're only able to achieve so much, and it was designed for normal individuals with no added or high risk factors. But we know that there's a subset of the population that potentially needs to be screened differently, screened better. And then when we look at the employer survey, we see some statistics of the level of interest, right, around cancer screening. So if we look at the chart below, definitely there's an interest to improve screening and early detection capabilities. That's probably the biggest bar there. Right behind it and closest, what can we do around risk and prevention services? Again, there's a lot that can be done because ultimately, if we're trying to reduce the cost of cancer care, it's either to prevent it or detect it early so we could intervene both at a clinically better point, but also at a more cost-effective point as well. Further down in terms of popularity are other things that have come up around sort of decision support and navigational support when people have cancer care at 63% and 42%. And then thinking empathy around the individual when they do have cancer care, making sure that if they need it, we are considering end-of-life care as well as part of the benefit package. So that's kind of the landscape of the employer opinions and areas of interest. Okay, next slide. When it comes to genetic testing and screening, specifically, this slide is talking about within the context of an employer health benefit. The reason I'm calling this out is much of this technology and capability can be ordered and can be used as part of medical treatment and care. So, for example, understanding the individual risk, guiding individual treatment, as well as early identification of cancer genetic testing can be done and often, well, maybe not often, but is ordered by physicians or oncologists as part of cancer care. But we are starting to hear and see that some of these tests are being offered either direct to consumer or through an employer health benefit offering, either as a voluntary benefit or just a supplemental sort of offering sitting on top of a traditional healthcare plan. So when does this screening matter? Without a doubt, it can matter in the context of risk assessment and identifying risk for cancer, because we know that certain genetic markers are very strongly indicative of a certain cancer. The most obvious one is the BRCA or the BRCA gene. But the more we test, the more we research, we're finding other genetic markers that also are suggestive, but maybe not as strong. So this is where the water gets a little muddy, where we see some correlation, but we don't understand it and we don't have causality. So the more we test, the more things we find, but not all things that we find are we fully knowledgeable about. Okay, so as we do that, that's some of the pros and cons that come into place. Some tests are very good, like pharmacogenomics, and I'll go into a little bit more depth, but basically some genetic markers tell us how you will respond to certain medications. So you can see the potential value of having that data information when a certain medication is prescribed, when it's not working, and whether it's a dose issue or a genetic issue. We can do early genetic test detection now as well. This is not recommended yet by the United States Preventative Service Task Force, but it is a capability. So the question comes down to, is there an interest to supplement standards of care with these novel and new capabilities that are not yet fully vetted, but have shown capability? So typically when I get asked about, when or should an employer be considering some of these tests, often it comes down to understanding the population demographics. Is there higher risk? Are there unmet needs? Is there an option and a need to address? Cost benefit always comes into the conversation, so we have to understand the current claims history. And then also look at the current cancer screening rates, because most of these tests would be supplemental to baseline cancer screening. None of these replace the U.S. Preventative Service Task Force recommendation. So obviously we would want to ensure that that's optimized to ensure that we get the best value. So these things come into play. And if there's interest in any of these tests that I'm going to go into, this would be the sort of the background information that's necessary to put all of these tests in context. Okay. So one of the innovations that we have decided to proceed and recommend MODA to consider is to start to, next slide, to start to shift left in the terms of really supporting women with self-assessment of cancer risk, and with that personalized data to get guidance and to connect them with best screening protocols and pathways. Right, so this is something that we had discussed as part of the 23-24 SEOW process, and this is something that on the innovation side is quite new, but it makes sense, aligned with our shift left to improve the screening and early detection of those with cancer, especially of women that may be of higher risk. And just to note that Gabi was highlighted last week at the White House as sort of one of the innovative companies focusing on improving women's health, specifically around breast cancer. So there'll be a lot of sort of visibility around Gabi and going forward, but it's something that we look forward to seeing how we can get some value and improve our breast cancer screening. Next slide. The liquid biopsy is a term that we call the ability to test through blood the presence of cancer DNA that may be floating within the blood. So it's kind of a biopsy, but it's really using a blood specimen. This company that does this is Grail. And again, you may have seen them on direct-to-consumer ads on social media. They are marketed very heavily. What they report to be able to do is to detect up to 50 types of cancer if that cancer has shed some of its DNA and is floating in the blood at the time that we took the specimen. So it can detect up to 50, but not all 50 cancers are easily detectable. So that becomes part of the statistics of this test. The test costs just under $1,000. The detection rate is about 1% to 2%. So what that means is if we test on a typical average population, 100 people, we may find 1, possibly 2 positive test results. Because this is finding the DNA in the blood, we would then have to do tests and workup to actually find where that cancer is living, right? So again, this is just a screening test. It's not a cancer confirmation test. So that would be the typical process for this kinds of service that gets offered to an employer group. Yeah, let me pause there.
Yeah,
Question.
so that number looks like 50,000 to 100,000 per detected cancer without knowing even where it is.
Potentially, yes, that is correct.
Yeah, seems to be in terms of screening, and then the interval of screening would be, is it $1,000 every year for every adult 40 and older? I mean, it's talk about the ability to break the bank.
Yes. So this is cutting edge. It's FDA approved, which means that what they say the test can do, they can do, which is detect 50 cancer DNA if it's there. It is not yet FDA approved because they don't have the study yet, which they're currently doing, which means they can't say that this will lead to a positive impact and reduce cancer rates. So that's kind of where it is, but it is on the innovative front. From a technology, the capability to detect shed DNA, I think is a valid technology. It will continue to persist, but that's where the science is. But there's some employers out there that are supporting this, recognizing that they've had the conversations of the pros and cons with me, and they're choosing to proceed ahead. So I just want to make you aware that you may hear of it. It is being deployed selectively. I would say maybe about 100,000+ individuals have been tested within the USA. But yeah. Okay. Let me move on to the next slide. Somewhat related, and I think I'll piggyback on Tom's comment, right? So we could do a lot of testing, but at 1% positive detection rate, and then even for that detection rate, we still have to figure out where and what cancer it is. The next logical question, clinical question is, can we do anything about it? Or more importantly, do we know what to do about it? right? So you can imagine a cancer being so small, one, you can't find it and the person doesn't have a symptom. Then so how do we treat it? Because right now our treatment options tend to be on visible symptomatic cancer. Either we're going to treat it with chemo, radiation, or cut it out. And now we have adjuvant therapy, right? So immunological treatments. One of the emerging technology is this concept of vaccination for cancer. So if we can detect cancer before you have symptoms, before we know where it is, then the only treatment that can work at that microscopic level would be our own immune cells, our immune system. So we have some early preliminary evidence that this could be a possible model. So it's not ready for prime time. We're just seeing it in the lab that this can work. So it's basically another form of cell therapy where we use the DNA and create a marker for T cells, our immune cells, that would go find those cancer cells that we can't see and then knock them out. So that's the emerging research that's underway. But potentially this plus the ability to detect cancer DNA before we feel any symptoms would be sort of groundbreaking, right? Now we can really, truly prevent cancer at its earliest stage. But this is to be determined. Let me pause there on that one. Questions about this technology and science?
So, Ian, what do you, your best guess as to the timeline where this becomes operationalized, where we would actually put it into plans possibly or consider it?
So if we use the timeline around gene and cell therapy, where there is valid, time-tested and endorsed care, I would say this, at the very least, would be that similar timeline, but I expect it would be a little longer. So one of the challenge with going after things you can't see is how do you make sure there's less harm to our own cells than the cancer cells, right? Because there's things to figure out. So I'm hedging because there's the unknown, and the unknown funnel is wide, but it's getting narrower with more experience with gene and cell therapy for cancer. So I would say that, and I'm not a subject matter expert on the technology, I am read on this technology. I would say within the next 5 years, we'll probably have some clinical trials, but that doesn't make it prime time yet. It just means we're starting to try to understand when and where this can work at the human level. So by the time it gets prime time, that would be easily at least 10 years out. And that's, a couch potatoes guess at this. Tom, your thoughts on this?
I don't have any greater focus in my crystal ball than you have. It's fascinating technology. It's fascinating application of science. The challenge is going to be having having clinical processes that can help, but do not that the cost of them are so prohibitive that they will be available only to an elite few. Getting back to the this whole concept of cost and efficacy. Yes, these things may get rid of some cases of early cancers. I mean, wouldn't that be marvelous? The and yet, if it costs, if each of these episodes costs $100,000 a year, you know, how do you afford that when we spend in the United States so much money on healthcare, and yet we have kids going hungry, you know, and our schools are inadequate. So it's the, you know, the medical, it's that big circle diagram of health, and how much of it is influenced by the medical intervention versus genetics, socioeconomic status, environment, lifestyle, you know, on and on and on and on. So it's the intervention, you know, instead of spending hundreds of billions of dollars, maybe we should be spending those hundreds of billions of dollars in different ways that actually would further increase. You know, this is philosophy. This isn't an answer to this. It's important that these things keep advancing, because what will happen is that they will change things over time. But society is going to have to enter the debate of prioritization, you know, of resources. Back in the days of the Oregon Health Plan, when we had the prioritized list, you know, it was, you know, the greatest good for the greatest number of people. And I don't know how this does make it to prime time, particularly as we look at costs. And we're going to be discussing this, Ian, very, you know, in a couple of minutes, when you start talking about actually genetic treatment, you know, that, you know, registers in at form at, you know, $2 to $3 million a case.
Tom, is this your way of announcing a run for Congress?
I'm not. I am not running for anything. I am running away.
Just checking.
Yeah. Okay. Yeah. No, send your contribution to siltabo.com. Vote for me.
Yeah.
Never thought of it, actually, Bill.
And I'll just add one more comment to Tom's, because the other thing to consider is, in the context of so early treatment of cancer, before you even feel ill, the threshold for side effects and adverse reaction has to be extremely low, because the alternative would have been just watching and keeping and doing nothing, which has sort of no harm at that, you know, over the time frame. Whereas doing a cancer vaccine, and we're starting to modify your immune system, and that carries risk, potentially significant side effects. So there's still, you know, potential for death from some of these treatments currently. That's too much of a risk for very early screening and prevention. And I also believe as our treatment gets better, then the pressure for vaccination goes down, because we can sort of do more just-in-time personalized cancer treatment and do it better. So.
And Dr. Chwang, is there a balance? Because not all cancers are fast growing or fast spreading, right?
Yep.
So there's some risk to treating, I think where you're getting at, to treating too early, because who knows how long it might take.
Yes.
And what about the patient's quality of life engaging in treatment for something that maybe would take 40 years to become serious?
And there's a psychological impact, right? Now you know.
Right.
Even though I can tell you this is not going to change materially, you're fine as a physician, but as a individual, you know, living and knowing that there's always this thing inside my body that's shouldn't be there, and hopefully won't grow. It's got some psychological toll. Okay, the next genetic area of growth is around the rest of the onomics. The most active one is what we would call nutrionomics and the gastrointestinal, or the biome. So we know that, you know, let me phrase it this way. What we consume is really the only way foreign substance gets introduced into our body, primarily, right? And that's medication and food. So there's a realization and appreciation now through research and science that our gut and how it processes the things that get ingested is hugely impactful, not just on GI health, but potentially a whole host of other things, including mental health, cardiometabolic conditions, cancer, and heart disease. And part of gut health is the biome, which is basically it's a natural fauna of bacteria that lives within your gut that helps with food processing, food digestion, nutrient extraction, etc. So the goal is to understand why the differences in each of our biome, gut biome, plays a role, and how can we include that into something that can be addressed or optimized as one lever to address some of these other chronic conditions. So there are certain tests that are now available. Again, the context that we're talking here is not, a metabolic expert physician ordering these tests as part of their workup. Some of these are now being made available to the consumer through point solutions being offered through employers as part of sort of gut health or inflammatory bowel disease management programs. So most of these are approved as a lab test, kind of like the liquid biopsy. There's limited approval or study to get approval from an FDA perspective, showing that this ultimately can have that impact of improving and changing an outcome. But this is sort of the emerging science. Again, there's more data that comes in because of these test results, and then understanding it in context of all the other things that influence cardiometabolic health, right? Or autoimmune and inflammatory disease is, as you can imagine, complex and multifactorial. So I don't think this is a single solution to solving that, but it could be a critical element to understand and address to tackle some of these more complex chronic conditions that can be costly, right? So immunological conditions like inflammatory bowel, when they're on a specialty RX, they end up being about $10,000 to $20,000 in prescription costs. Thoughts, questions, comments, experiences on this?
This is just some good fuel here for future thinking. I like it.
Yes. So the next genetic test, again, is available. Physicians can order it when it's deemed medically necessary. But these tests are also made available as part of the genetic testing offering that these vendors offer. Pharmacogenomics basically is looking at just the genetic markers for things that we know influence or impact medication metabolism, and really two parts, either influencing how well it can work or the potential for side effects. So combination of those two. The types of medications that so far we've identified, right? So we don't have it all figured out, but the medications that have come up as showing some correlation are around pain medications, certain cardiovascular medications, including blood thinners, and mental health medications like antidepressant medications and things like that. So it's very selective, and it's really just 45 genes that impact 300 medications. The benefit is somewhat theoretical when you come at it from a population approach, right? It's one thing for a physician to be stuck with a patient not responding to a medication, and that medication really is the best choice. So if they have to decide, do I switch to a suboptimal one because genetically this person's never going to respond favorably, or do I tinker with the dosage in a way to continue to try to optimize. That's a different scenario than going direct to consumer and saying, okay, let's get your genetic, your 45 genes tested. You may or may not be on any of these medications. You may be in the future, but we don't know. But let's get the data for your genetics for these 45 genes so you have it available. As you'd imagine, to make that information of value, it means one, whoever prescribes any of those medications later on needs that data available, ideally in their EMR. So having this test done at the employer level, we've got to disconnect where that data lives. And secondly, we need that information to be with that individual over time, right? It's not just, here's the information, here's what you need to know now, and then you're done. It literally, the data is complex. Genetic data is not a simple sodium equals 140. So it's not something you can just keep in the back of your mind and have that pulled up when you need to. So without those two parameters, having these tests done in advance of a medical need, theoretically can be beneficial prospectively, but it requires that individual in the right context to be in place. So that's sort of the clinical point of view I have on that. However, the test can be truly valuable and useful in certain circumstances. Okay. So that's around the personalized genetic testing space.
Ian,
yes.
Ian, do you have any idea of how much the pharmacogenetic testing is happening now?
So am I aware of certain employer groups that I have relationship with that have covered it? Yes. Very few.
Okay.
So it's not common. Have I seen claims for these as part of medical care? Similarly, yes, but it doesn't get ordered very often, right? So this data is complex. So a typical family physician would still have to know, well, if any of these 45 genes come back with a positive, what do I do with it? So it tends to be ordered by the very specialized specialties for very specific reasons.
I can just add on, some of the colleagues I work with on some other clients did a survey of some of the large PBMs and the carriers to try to understand what the prevalence was for employers covering these kind of things. And almost universally, the employers will cover that patient specific, especially around certain cancer drugs for the genetic testing. But as far as preventive genetic testing before any treatment, almost nobody is covering that. It would be very, very rare.
Okay.
Is that in the same category as the genetic testing they do for breast cancer that I see famous people on TV making decisions on?
Like the BRCA gene?
Yeah, that's the one I couldn't think of.
Yes, literally they're just targeting the 45, right? Your genome is so large, it's basically, they've had to package it and say, here's, for this price, we'll test these 45 genes, and all these have some potential impact on your medication. Typically, there's another package around cancer risk markers, and then a third one typically is around the cardiovascular risk markers. Those are the three that are most common in terms of the commercial packaging offering that I see.
You see this as kind of a new industry in the medical field, or that big places like Johns Hopkins and things like that will take this on and see about the databasing and AI work that goes on into that evaluation of the database?
I'm seeing providers operate it because they, I think 23andMe opened up the door, right? But they were testing for all sorts of things. Many of those are not medically important or relevant. These tests are, and some provider are offering it within their precision oncology service offering, either as a, an option for the community. So basically a counter offering to a third-party vendor, or it's still within the domain of their standards of care practice. Meaning if you're seeing me for oncology or for mental health, this test is part of my scope of services that have been standardized, and they position as sort of, we're the cutting edge providers for this specialty. So I see those two flavors.
Do you see this falling under the pharmaceutical industry at some point in the future?
Sarah, what do you think?
I would say it depends. I mean, certainly we've seen, as we're getting more and more specialized drugs, there's a lot of drugs that are, even in the FDA label, it indicates that in order for this drug to work, it's for people that have a certain genetic mutation. So for example, there's those drugs for cystic fibrosis, and they only work for people that have this certain genetic deletion. And we're seeing that with some of the gene therapies as well. As far as the manufacturers of more traditional drugs, like drugs for depression or cardiovascular disease, I haven't seen that yet. I think that's probably less likely than for these really specialized conditions.
But for the specialized conditions, I wouldn't need to test 45 genes. We would do
No,
targeted.
you know what you're looking for.
Yes.
Yeah.
Very interesting.
Okay, Sarah, pass it to you.
Okay, let's go to the next slide and we'll talk a little bit about gene and cellular therapy. So moving away from some of the testing, moving towards using some of this technology for treatment. So there's a couple buckets of these very high cost drugs, and we've talked about them a little bit before. There's gene therapies, and then there's cellular therapies. Gene therapies work by replacing essentially a gene that's missing or is broken. And they do that. If you look at the bottom of this slide, there's a healthy gene that is put into a virus vector, and then that is infused typically into the patient, and that can help replace their gene. It's pretty amazing. I've got another slide that shows which of these have been approved and where the market's going for these. The other category is cell therapies, and what these are is they're generally treatments for cancer, and they take the body's own cells, bioengineer them, essentially turn them into cancer-fighting machines, and then infuse them back into the patient. So you've probably heard about CAR T. That's the most common cellular therapy we hear about. Administering these can be complex. There's some exceptions. Some of the gene therapies, it's really just an infusion, but there's other gene therapies that require the patient to go through a full ablation. They need to go through chemotherapy before they can be administered the gene therapy. And that's kind of, that's one of the reasons we're seeing kind of slow adoption for some of these, because the process to get them isn't necessarily fun. Let's go to the next slide. Yeah, so these are the products on the left. This is what's already been approved by the FDA. You can see the names of the drugs, what the cost per dose is. And then on the right are ones that the far right, these are the ones that we're expecting to see approved in the next year or so. Of these, the ones I think we've seen the most from is Zolgensma. That's the third one on the left. That's a gene therapy for spinal muscular atrophy, which is the leading genetic killer of infants. It's proven to be so far pretty amazing. Babies that get Zolgensma near diagnosis, which usually results from a newborn screening genetic test, it looks like they're being able to hit milestones that they otherwise never would have been able to hit, things like being able to crawl or walk. Typically without treatment, the most severe form of spinal muscular atrophy, the children don't live past their second birthday. So it really is making a huge difference for some of these kids. Down at the bottom, you can see more recently, we've seen approvals for hemophilia. There's actually 2 products now for hemophilia B, the second one just got approved like last week. And then there's also Roctavian for hemophilia A. All of these are in like the $3 million range. We have not seen much uptake of the hemophilia gene therapies yet. Even though they've been on the market now for a couple of years, it's been a slow level of uptake. I think there's a number of reasons for that. Part of it is a lot of people with hemophilia are managed okay on hemophilia factor right now. Even though that hemophilia factor is expensive, people feel comfortable with that level of treatment. There's also some concern. We don't have long-term data on any of these products. And so not everyone is willing to take a chance on a gene therapy knowing that it might only work for 7 or 10 years. We don't know yet what happens beyond that. But I saw some data, I think just last week, it was like fewer than 10 people actually got treated with the hemophilia gene therapies in 2023. So we're still really waiting for it to ramp up. You can see the list of the cellular therapies. They're the ones with the little cancer ribbon on the right. Those are all of the CAR Ts. There's several of those. They generally are about $500,000. In all cases, these are the costs for the drug themselves, the actual little vial of the drug. It does not include the associated costs, like for some of these that where the member needs to be receive cancer, be ablated, any kind of hospitalization stay, aftercare, none of that is included. These are just the costs of the drugs themselves. So there's been a lot of discussion in the industry on, as we're continuing to see more and more of these products come to the market, are there opportunities for innovative purchasing arrangements? How can the cost be spread over time? How can there be value-based arrangements? Because right now it's a fairly small population of people who qualify for these treatments, but over time that could change. Yeah, Robert, you got your hand up.
Yeah, Sarah, thanks. I know that there are gaps in medicine costs comparing us to Europe and Canada. Does that apply here too, or is this pretty standard?
There are gaps, and also not all of these products are available in Europe. In some cases, the European regulators have not been able to come to agreement on price or haven't found them cost effective. So it depends. That answer your question? I also wanted to point out sickle cell. So there were 2 treatments for sickle cell disease that have been recently approved. They're both gene therapies. One of them is working with CRISPR technology, which you may have heard of. And then the other one is a virus vector similar to some of these other gene therapies. The sickle cell disease is a more prevalent condition than a lot of the other conditions we've seen treated with gene therapy. So far, we haven't seen a lot of uptake for the sickle cell treatments, but part of that is that's one of those that requires chemotherapy, a hospital stay in order for administration. And then there's a lot of concerns about that for people. Some employers are talking about things like fertility preservation or egg freezing for people who are getting sickle cell gene therapy treatment because it can affect their fertility long term. Let's go to the next slide.
Also, just a comment with the virus vector, there's also some concern of because we're piggybacking the gene in a virus, you may have one shot of this therapy because once your body knows that this virus kind of was a foreign entity, it's going to develop its own immune response against it. So that's why sometimes, well, the thinking is if you're otherwise well managed, delaying the use of this treatment to only when you need to is potentially a prudent approach as well.
Right, yeah, because if it turns out that it only works for 7 years and now you're 7 years down the line and you're not eligible for a second gene therapy because you have antibodies to that virus vector, that might put you in a more difficult situation than if you just received it today. This slide, I just wanted to show the pipeline. So on the right, that little circle, you can see those are all of the different cell and gene therapies that are in development currently. I didn't add them all up, but you can look and see that it's a pretty large number. And we've heard that by 2025, FDA is anticipating that they will review and potentially approve between 10 and 20 gene and cell therapies per year. So this has kind of been bubbling up in the background while we've all across the industry been talking about GLP-1s, metabolic disease. There is this coming wave of gene and cellular therapy that we need to continue to watch and continue to work through. CMS for Medicaid actually has a gene and cell therapy. I forget what they call it. It's like an innovation project through CMMI, and they're working specifically on sickle cell disease treatments, trying to find a mechanism for value-based purchasing that state Medicaid programs can latch onto. It's still in really early stages. I think they're having conversations with a lot of state Medicaid agencies to figure out what that will look like and how it will work. But it's just another example of how many different payers, many different groups are really trying to crack the nut of how are we going to afford all of these really innovative therapies over time. Any other questions or comments on cell or gene therapy? Okay, let's move on and we can talk about some of the other pharmacy related topics that we're watching. Next slide. So HIV. So HIV is another disease that has kind of been under the radar over the last 5 to 10 years. But there's a lot of innovation coming in HIV that we definitely want to keep an eye on. One is longer acting treatments. So in the last couple of years, we've seen approvals of long acting injectable treatments for HIV. You might have seen these advertised on TV. I know I've seen them, I think, during NFL games of all things. And so these are like once every 3 months or once a month injectable. There's an option for treatment and there's option for prevention of HIV. And we're also seeing even longer acting drugs in the pipeline that the manufacturers are working on developing. So the manufacturer of Cabenuva is studying a version of that drug that could be dosed every 4 to 6 months for treatment. So that could be kind of a game changer with people with HIV to only get a shot 2 or 3 times a year to continue to keep their virus at bay. And then Merck is also testing a once-a-week pill option, so 1 tablet a week to treat HIV. So we've come a long way from where we were 20 years ago, where you heard about people with cocktails of drugs that had to basically structure their day over when they had to take their medication. Also seeing some new treatments and new combinations of treatments. So we saw a couple of products approved for multi-drug resistant HIV. One is a long-acting injection. It's every 6 months. It has to be used along with other HIV medications. And then there's also an oral option that can be taken twice a day. And so these innovations are treating a form of HIV that previously was untreatable due to multi-drug resistance. And then we're just seeing more products, more mechanisms being studied. So over the next 5 or so years, we'll see even more treatments for HIV. HIV vaccines, many of us had hoped by now we would have a vaccine for HIV, but we don't. There have been multiple trials and continue to be multiple trials for vaccines. One of the more promising ones was Johnson & Johnson's Mosaic vaccine, but unfortunately they abandoned it in 2023 due to, it turns out, lack of efficacy. But there are still more than 10 discovery trials that are underway or planned to start this year. So there's continuing work on an HIV vaccine, but we're not likely to see it anytime soon. And then just to tie it back to gene therapy, Washington University, there was some news. They received a grant from the NIH to develop a gene therapy against HIV. And what that would do is it would modify B cells to manufacture antibodies specific to HIV. So kind of like a CAR T, only instead of treating cancer, it would target HIV. So that's pretty exciting, but it's really out on the frontier right now. And it would not actually eradicate HIV from the body. It would keep the virus low enough so it would be a functional cure for people, and their own body would continue to attack HIV. So that's pretty cool. Any questions, comments on HIV? Not on this slide, and not necessarily an innovation anymore, but something that's really exciting is, there are pre-exposure prophylaxis. People can take a tablet a day to prevent HIV. It works very well. Truvada was the first product approved for PrEP, and there are generics available for Truvada now, and those generics have become very low cost, like under $100 a month. And so there's been a lot of public health efforts to try to increase the utilization of PrEP in the community so that we can move upstream and reduce the number of people that ultimately become infected with HIV. Okay, let's go to the next slide. I couldn't get out of here without talking about weight loss with all of the discussions that we've had. And mostly what I want you to know here is that the GLP-1s that we've been talking about at SEOW and in the board meetings, these are really the beginning, not the end of what we're seeing in terms of development for weight loss. So right now there's 114 different drugs that are pending in the weight loss pipeline. And those products are a mix of how they work in terms of mechanism of action. There's a mix in terms of how the drugs are taken. Some are oral, some are injectable, some are once a week, some are once a day. And there's multiple different manufacturers that are in the game as well. It's not just Lilly and Novo. We're seeing a lot of different manufacturers jumping in and testing products for weight loss. 8 products are in phase 3 clinical trials, and phase 3 is the closest to FDA approval, and that's where they're studying for safety and efficacy in human volunteers. And so, those 8 products, should they get approved, we could see those within the next few years. There was some news earlier this week. Amgen has a product. It's an injectable, and it's a mix of a GLP-1 and what they call a GIP. And it works a little different from Zepbound, which Zepbound or Mounjaro. What that one does is it activates both receptors, whereas this new Amgen drug activates the GLP-1, but actually inhibits the GIP. And so far from that one, they're seeing faster weight loss in the first several months of treatment. And it looks like there might be some potential for more longevity of weight loss even after the drug is discontinued. Downside is it looks like there might be some more potential for side effects, especially GI side effects and nausea. But just an example that this is all moving quickly, and we're continuing to monitor what's going on with weight loss drugs. Any comments or questions here? And I know that the font is really small, but I mostly just wanted you to see how active the market is.
Wow.
Right? Over time, right, this many competitors, if all of this stuff works, or at least if a decent sized portion of this stuff works, we should see the power of competition bring prices down over time. And we'll get more data on how these drugs work and how people can succeed in weight loss. So overall, it's exciting. Okay, let's go to the next slide. So Bill, when I was talking to you the last time we were in person, one of the things you asked is, what's the next big thing? What's the next big thing we have to watch in terms of drug treatment? And what a lot of us have been talking about is this. It's metabolic dysfunction associated fatty liver disease, which is a mouthful, that goes by MAFLD. MAFLD is the buildup of extra fat in the liver cells, and it's not caused by alcohol. So typically, traditionally, you've seen fatty liver disease related to alcoholism or heavy drinking. But as we've seen growth of metabolic syndrome, cardiodiabetes, we're seeing more people that have this buildup of extra fat that's not caused by alcohol. And in terms of definitions, if more than 5 to 10% of the liver's weight is fat, that's where it's called fatty liver. And you can also see the technical name there. Usually it causes no signs and symptoms, especially in the early stages. So this is a challenging disease in terms of there's not a lot that goes on right away until it passes a point where it needs treatment. The more serious form of MAFLD is called MASH, or metabolic dysfunction associated steatohepatitis or MASH. This used to be called NASH, which was non-alcoholic steatohepatitis, but it's been rebranded to MASH. That's the most severe form where the liver has actually swollen and become damaged from the extra amount of fat that's being stored there. It is most common in people that have the conditions that are treated by the GLP-1s or other weight loss techniques. They are more likely to develop cirrhosis or liver cancer. This one was surprising to me when I was looking this up, but MASH is expected to become the leading cause of liver transplant in before 2025. So by the end of this year, we're going to see more liver transplants due to MASH than any other condition. How do you treat MASH or metabolic dysfunction associated fatty liver disease? It's lifestyle modification, right? All of the things we've been talking about: weight loss, nutrition, exercise, and avoiding alcohol, and then treating other conditions. We did see the very first drug approved for MASH, and that was called Rezdiffra. It was approved this year. It's $48,000 a year. And the overall pharmaceutical market for MASH is expected to be $35 billion by 2030. So this is a pretty big condition. Drug manufacturers are active looking for treatments for MAFLD and MASH. Some of that market could very well be GLP-1s. So some of the GLP-1s now are in trials to determine if they can treat or reverse this fatty liver disease.
I'm curious about the third bullet here. Ultrasound is not an expensive test, so why is it needed to be other things have to be ruled out before you do the actual imaging?
Oh, because so you see high level of liver enzymes, and Dr. Chuang, you probably know more about this than I can, but I think there's other types of liver disease that can be more obvious that you don't need an ultrasound for first.
Yeah, we're basically, we want to detect when there's physical structural change to the liver, like fibrosis and scarring. So this condition is kind of a one-way street. Once you get to that scarring, there's no going backwards. And then we're trying to rule out other things that can cause sort of elevated liver enzymes. Could be hepatitis, alcohol use, medications, other things, infections.
So they're quick. It's a quick rule out. It's not like you're delaying the price of an ultrasound for months while you figure this out. Okay.
No. Typically, if I'm ordering ultrasound, it's to rule in, to be honest. It's like, okay, it's not any of the other things, and I just really need a visualization to see what the liver looks like and if there's any physical structural indication. And some stats, it's about a third of those with obesity will progress if left untreated to this condition, and similarly about a third of type 2 diabetes. So again, this is the downstream risk and potential health outcomes, but also cost as well.
Any other questions on fatty liver disease?
So is there data on just what the expected percent of population has non-alcoholic liver issues?
I think there is data on how much we know of, but a lot of this hasn't been diagnosed. But I think, as Dr. Chuang just mentioned, we know what portion of people with obesity or type 2 diabetes progress to this, so we can calculate what the likely prevalence becomes over time.
And it doesn't help that we don't have a nice, clean ICD code for this. That's the other challenge, is how do you go find it from data? Okay, let's move on to the next section. Yeah. Let's go back to technology and let's see what else is happening. So, medicine tends to be a reactive, disease-based model of care, right? We need the patient to tell me as a physician when you don't feel well, or I need you to schedule an appointment when you feel you have a need. But but so much of the health part of healthcare is the prevention, self-care, condition monitoring, and things like that. Which, to be honest, the brick and mortar, office-based, and as a physician, we're probably not the best ones for that. So what you've seen emerging with the advent of the smartphone are apps and technology that, for those that are inclined, what they call the digital quantified self group of people that do want to take their own initiative to track, monitor, and learn about their kind of biometric parameters. So on one hand, it is digital scale, but even things like a digital EKG is very informative. For a layperson, you can only do so much. For example, I travel. This is my digital EKG and my O2 stat. Between the two, when I travel, there's most acute cardiac stuff. I can at least do an initial triage. That's how capable these portable devices are. But then you stretch that out to the average individual consumer, it's still informative. If nothing else, it defines a baseline by which they can engage their physician to have conversation of what's their norm is and when to start treating certain potential chronic conditions can be very helpful. Next slide. So from a condition tracking capability, there's probably 4 chronic conditions that there's been enough utilization, some study and research out there, as well as technology that's reasonably useful to support their care. The 4 conditions are sort of diabetes, epilepsy, depression, and heart failure. Diabetes is probably the one you've seen the most as we move to sort of continuous glucose monitoring as the next wave beyond finger stick glucose checks. So now you can literally see how your fluctuation in glucose changes in response to meals close to real time. So that sort of feedback loop and understanding why food choices matter, sequencing of food choices and timing of food and meals is important. Depression, various both monitoring and assessment capabilities, but also supportive resources and tools to help with mindfulness, cognitive behavioral therapy, self-help, and things like that. So it's emerging, and it's one of those spaces that we learn through more participation and use of these technologies. And again, it's that big data concept as these researchers tap into that. But because of the reliance on data and sort of the aggregation of information, few challenges exist, and people who sign on need to be mindful about the data ownership, right? Part of this is for those who develop the app or the technology to expand their knowledge, to apply machine learning and AI to discover other things about that can be revealed through the data. Trust and security. Who else has access to this data? How does my physician get information about this? And obviously the concern, does my insurance, especially life insurance or other commercial entities that may want this information, becomes a risk. And for anybody who's paying for this, how does this get reimbursed? Is this typical healthcare, medical care coverage or not? And how do you quantify an ROI on this as well? So these are things that are in works. And again, it's one of those evolving space where early adopters will help inform those of us that are sort of keeping a watch on this. And through formal research and peer-reviewed publications, we'll hopefully learn about the full capabilities as we move forward. But if there's any interest on this, I would consider this to be sort of part of the early adopter kind of mindset and positioning for these technologies still.
Okay.
Dr. Chang,
Yes.
just to add on, one of the things that's really interesting, I think, with the diabetes component in the CGM. So one of the manufacturers did get FDA approval to market an over-the-counter version of CGM, and we're expecting that this summer. So that could really change the landscape of how many people are trying CGM, maybe for diabetes, but maybe maybe not, maybe to more better understand how their body is processing sugar or for fitness applications. So we'll see where that goes.
Yeah, and just a personal anecdote, I did take advantage of a free use of CGM, not because I had diabetes, but just to understand my body's own metabolism. And there are just always ways to improve, our lifestyle and choices, right? Outside of the context of an actual condition or disease. And that was sort of the takeaway is like, oh, what I read in the textbooks was true and relevant to myself. I don't respond to berries all in the same way. So just knowing that, my body has a preference for strawberries and blueberries, but not other, like pineapples, I spike. That's personal to me. And unless you see your own data, you don't have that insight. I don't have to react to it to control my condition, but given that knowledge, I can sort of self-improve as I go. So helpful in that way.
So my input here is that, so I'm in a heavy engineering company, a lot of younger generation, middle class. My company pays for about 2/3 to 3/4 of an Aura ring, if you know what those are. And I'm amazed at how many of them I see at work. And now there's one on one of my own kids as well. And these people are paying money per month to get analysis on how their personal health is doing through these rings and making lifestyle changes. And I'm getting those testimonials from numerous people at work. And now my daughter, that they're actually making lifestyle changes based on this Aura ring. And now I'm forced to consider getting one. But you're literally paying $6 a month to get this data. And that's not a problem. People are signing up for this in droves. Now at Best Buy even, right?
Yes, so it's going to become more common and more prevalent. Samsung has their own ring now, so there's going to be options for many people. Next slide. And in the context of self-care, self-monitoring, I would consider skin cancer screening as an opportunity to do more of that as well. So it is important for a physician to sort of assess a suspicious mole, but it's also equally important for you individuals to keep track of that, because unless the physician knows that, hey, there's a mole that last year looks different than it does this year, we don't have that context. So what better way than to take an image of it, and an image that's saved, and over time you could have subsequent image to do comparison. There are sort of self-help apps to help you with just the tracking. And the one that I pulled up is just local to Oregon out of OHSU. It's a free app, and it's good at the tracking piece, right? So I would suggest if those who are interested and want to use this, it's a good way to see, does this look different now than last year? Because I can't remember all the details. But if you do notice something odd or suspicious, it's a good reference data to bring to your physician and say, this is what it looked like last year. Here's how it looks like this year. You don't have it in your medical records because you don't have the image, but I have it. There are now sort of AI companies that add on to these images and will do some of the analysis of the image. Because it's a image, it's got pixels, and pixels becomes very quantitative. So it has the ability to look for slight variations in color or differences in margins. So even though you're taking two pictures and they may be slightly off angle, the AI could handle the angle of view and the difference in scale and basically make a judgment of whether your margins are changing if it's starting to grow larger and uneven. So those are opportunities to, again, help those who are interested and willing to be more proactive in their self-care, to take ownership and to advocate for themselves, as well as to optimize the care experience. So again, that's an example of going beyond the traditional models of care innovation space. Another one that's sort of tearing down the traditional model is the next slide. Again, I'm using a local healthcare organization, OHSU, as a exemplar, where we know that, close observation and management of premature babies is important. Typically, we've done that in the hospital. But we realize the hospital may not always be the best environment, right? It's not the warm and fuzzy place that would be more nurturing and conducive for not just the preemies, but the parents as well. In addition, we also know that hospitals carry an intrinsic risk, and that risk is hospital-acquired infection. What better way than to get them home where they're isolated amongst just their family immediately, immediate family members, and to continue the sort of the close medical monitoring and observation. So OHSU has a program and that supports newborns, specifically preemies, to kind of get home faster, yet without adding health care or medical risk to letting them go home early. So obviously there's strict criteria for eligibility. There's ways to stay connected. There's a digital platform for remote care and monitoring. But in return, these kids get to go home. They're in the home environment. They're close to their parents 24/7, yet they're still connected to their OHSU NICU. So again, thinking differently, letting traditional physical barriers not be impediment to optimizing the care experience. Next slide. Another example where we're again moving beyond the traditional models of care. Typically for mental health, treatment ends up being some session, some coaching, some counseling session face-to-face with a psychologist or social worker or psychiatrist. One thing we learned through the COVID experience is there's good acceptance as well as efficacy using a virtual model. So not only do we remove some of the barriers to access by offering virtual treatment and care, but we also are finding that people are actually potentially more comfortable, or a subset of people are comfortable not having to feel like they're sort of revealing very intimate personal things directly to a person in a live setting, as opposed to going through a virtual conduit. And then they're starting to explore alternative ways of treating beyond traditional talk therapy through augmented reality, where through imagery, through an augmented virtual reality headset, can we sort of address things like phobia or other mental health conditions through a combination of sensory input as well as coaching and behavioral therapy. So this is emerging and seems to be extremely positive. I would say most of these are sort of not in standards of care. They're selective places where they're not only doing the research behind this, but also seeing how we can advance and define standards of care for when and where this can be most useful. Okay, the last section that I'll go into is purely focusing on data and how do we, in the world where we know that there's many factors that ultimately lead and impact the various components of health and well-being, how do we get big data where it is truly big enough? Because anything that's missing out of big data becomes something that is overlooked. So there are a couple of examples that are sort of public-driven collaboration where it's recruiting the average consumer to join in the effort. And by joining, they learn a bit about themselves. There's some data sharing. There's potentially of comparing yourself to your peers, but they are basically taking advantage of your data to add to the collective pool. One is a national effort called All of Us, and it's run by the NIH. And I provided the link there, so take a look. Full disclosure, I did volunteer and I am participating in this because as you've sensed, I'm curious about myself and I'm always a clinical researcher at heart. So by participating and answering questions and potentially also doing submitting to test results, I will learn and see where I look and how I fit relative to the population as the data becomes revealed. The next one is probably more local. It's specifically Oregon, the Healthy Oregon Project. Somewhat similar, but it's a project by OHSU again, and it's looking specifically at Oregonians and understanding some of their social determinants, and other health parameters. And it's a project that is available to those who live in Oregon. And again, it's potentially helping to change the mindset that approaching health is both individual goals and effort, but it's also community-based and broader in its applicability and relevance. So we kind of have to understand both parameters, and these efforts are, in a way, helping to create knowledge around that. Okay, so that was a quick tour, and but that's not all that's out there. And like I said, it's just what we thought were the things that have some relevance, either to OEB potentially at some point in the future, or something that's worth tracking because potentially over time it will become more relevant to our conversation. And that's how we kind of selected these for discussion and exposure to SEOW today. So with that, let me pause and open it up.
All right. Let me start, if you don't mind. When I read this yesterday and now hearing Sarah and Ian present it today, yeah, I'm the science nerd and I found this presentation incredibly fascinating. Yes, it's not everything, but just to look out there and see what is striking the eyes of Mercer, as potentials and looking into the future and understanding, things that are next on the doorstep and what's further down the road and how we're evolving healthcare strategies based on the technology that the industry I do work in, which is your data, mass data, cloud, AI work that the industry I work in enables. How it's coming to fruition in medical healthcare is just awesome. And so this is great. And I recommend we have this kind of presentation at least twice a year, where we just do that lookout and just see what's happening out there. And my takeaway from this is I want to go to an AMA conference with a group of us and just go sit in with thousands of these people who work on this stuff and just hear them and listen. I'll stop there. Open the floor for everybody.
Yeah, the only thing that I would add is you ended up covering a pretty broad spectrum of things that are happening, and we need to be looking at it. Some of it will feel like it is running over us. Parts of it will feel like it's an opportunity. So we need to be kind of cognizant of what we, really what are our options, what are the things that are going to help us in terms of meeting the pressures and challenges of providing the best that's available. So again, I agree, Bill, entirely with what you're saying in regards to looking at it, thinking about it, still holding ourselves to bringing on board things that not just are the new shiny toy, but ones that have been where there's data behind efficacy, and that's the challenge with innovation, is to make sure that if we're going to participate in research where the issues, let's say, still up in the air in terms of efficacy, acknowledging it and making sure that we're collecting the appropriate data to be able to answer the question in a year or two. And we're doing that. There's OEB and PEB are big enough that when we do things, we have an incredible population to do that real world beta testing, something outside of the clinical trials, which oftentimes are, the population that they look at is pretty darn skewed. So real life observation and experimentation is also critical. So I'm not suggesting that we wait for 5 years of data before we jump on board somewhere, but definitely that we have to be cognizant of efficacy. It's in the SEOW definition.
Ali, followed by Ian.
Thanks, Bill. And yeah, kind of along the same lines as Tom's comments. I mean, I think we have opportunities, the boards have opportunities to pursue things of interest that make sense through SEOW, through innovation work group, through our carriers that also come and report on innovations at least once a year. And then how we get further along is through the renewal process. So through the letters, we ask for information from our carriers and to explore things that the board would like to look into further. And I mean, I think along the same lines as Bill's comments, these are the kinds of reports that maybe we can entice some people's interest in SEOW and on innovation work group as we try to fill some of the vacancies that are upcoming.
And I agree. The object of this kind of reports, to me, anyways, for me, is not that we're going to take everything that Mercer lays on the table.
Right.
It's really churning fuel for thought on things that are important and seeing how it relates in the bigger picture, but always focusing on what is important to us. Right. Ian.
So question to leadership, Tom, Ali. To Tom's comment, do you envision a threshold where it is innovation? We don't have good sort of evidence-based studies yet, but it's suggestive, but it's really to be an innovative early pilot to test something out, to be part of a broader engagement. Do you see that threshold where it's not fully quantified as efficacious, but early data suggests, and to your point, OWEB has a population size that helps with any sort of sample size dependent evaluation? How do you see the role and the opportunity or not?
Well, I think we're doing it actually with two things that we added this year, Gabby and Doula. I mean, I think that my hope is that we ask the plans to specifically look at, complication rates that they've had, C-section rates, things like that, and to see whether or not the addition of doula coverage, the addition of Gabby, we're changing stage at time of diagnosis. So you can't do it. You can't do many of those. You can't do 10 or 20 studies at a time. But where we have been selective in terms of adding on innovative issues for them to try to set up ahead of time the monitoring structure so that we'd be able to actually look at the outcome of these innovative approaches.
Let me let Sue in. She's had her hand raised.
Yeah, thanks, Bill. Thinking about that threshold, and I was also thinking about your comment, Tom, relative to keeping our eye on the ball, staying focused. And one of the things that, again, first and foremost, thank you, Ian, for incredibly comprehensive, coming originally from healthcare into education. I'm right there with Bill, totally geeked out. So thank you, appreciate that. The point I want to make here is thinking about that digital wearables and thinking about the services that we currently provide. I'm thinking about our workforce, our teachers, our counselors, our special ed teachers, individuals who are under incredible stress on a daily basis as they work with our kiddos, and how practicing or doing some trials similar to what you described, Bill, where there's a discount potentially for an Oura Ring or other wearables that help them to see what their own personal health is on a daily basis, and then going and connecting them with services, be it EAP or be it Weight Watchers or whatever the series, the suite of care that we have, so that they know that individuals feel that additional care. They're able to be very targeted about the care that they get, and we're getting data back relative to how effective that care is, because they've made that connection based on their own personal health data. So I think it's an exciting time, and I'm sad to be retiring at such a time when so many great great innovations are coming into play. Excited to see the GLP movement, and I think that's also part of it. Some of the things that we are seeing today that may be just on the brink of horizon, I think are worth tracking. For the very reasons that, like we're seeing with the GLP-1s, they were brand new and innovative. We weren't sure where they were going, and now we can see that it's moving in a critical mass direction. And so, again, grateful for that opportunity, but would encourage us to think about how we can get some synergies out of some of these newer pieces that are just coming onto the threshold and connecting them to services that we currently already offer and have good data on.
How about Andrea, Robert, Greg? Any comments you want to jump in here with?
Yeah,
sure. I look forward to when these various innovations line up with our triple aim window. Yeah.
Greg?
Yeah, I just some of the things it's interesting because you don't see a lot of that out there, and it's things that we have no clue that are even on the market yet. And a lot of it to me is like, wow, there's a lot coming that we are going to have to look at to see if, number one, as the GL1, we have the ability to put these things into our plans. And it also, to me, kind of as we're looking right now to do, we have some work to try to do maybe legislatively or with some groups that help us legislatively to get some of these things coming, to get some funding and to help us with our 3% we only have, to try to help, bolster that because of some of these things that are coming that will in the future really, if some of these things are doing what they do, it will really help a lot of our individuals out. The ability to tell prior to cancer if you have cancer, even if you don't know where it's at. There's a lot of things that are just like, it's huge, breakthroughs that, a lot of people don't even know that are there. And we're going to have to realize get an idea of what we can offer to people. So yeah, it was very informative. Thank you.
I think honestly, I'm just excited to see science fiction become reality. That's that's a lot of what I see. So I'm the nerd too. Like, I think this is just so fascinating and hard to even kind of comprehend. Like, wow, it's coming, and I'm really grateful that I get to hear about this now. That that I have a position where I can hear about it, because it's amazing. So thank you.
Enrique, let me invite you to throw a comment in here.
Oh, thank you. No, I just feel also positive from the feedback and the scientific reporting. I look forward to us as a board to at some point be able to add all these benefits with less major financial implications for our members, and looking forward to collaborate with everybody on how we can help our members. Thank you.
Ali, hand up.
Yeah, Enrique kind of brings me back to reality. A couple of things I was going to talk about this afternoon in the director's update is, OWEB and PEB have a real reputation of offering cutting edge benefits over the years and bringing innovation to the marketplace. And, but then, and it's attracting a lot of, huge new school districts and entities like we've never seen before that are interested in joining either PEB or OWEB. But then you hit with the reality of that 3.4% cap, and that's the other update is, hopefully getting some flexibility around that. And but yeah, I mean, I think overall the level of innovation that we see coming out of OWEB, was really attributed to SEOW. It starts there, and over the years has really been a boon to innovation and innovative plan offerings.
As I'm listening to everybody, I'm still kind of focusing in on, our shift left and getting individual members to become more engaged in their own personal health, and wearables is where it's at, right? Getting that information into the individual members' hands where they can make adjustments in their own way to their lifestyle is what we're trying to get to, right? How do we get members to really take a position of positive change in their lifestyle management? And wearables is here, right? And we just have to kind of make them engaged in that. But I'm fascinated by all the genomics that were discussed here. I know that's way out there in the future, but isn't it cool, right? So, Tom.
Yeah, the only what Ali just commented on in terms of the innovation that SEOW has done. We need to acknowledge that it is because of the collaboration that we've had with our carrier partners. I've been on SEOW now for 8 years, and we've maybe we're taking credit, but the plans have been the ones often, along with our consultants, have been all pulling together and coming up with ideas and then testing them out and things like that. And SEOW can help, can analyze, can direct. It's the consultants and the plans that are doing the work, supported by our, OHA staff for both OWEB and PEB. So if you don't have all the 4 elements, the board with its SEOW, the OHA staff, the consultants, and the engine for this innovation plans, without all 4 of them working together, we won't get what we need. We won't move things forward. So that's kind of my parting words as such. Keep that collaboration going. That's so critical for us to be able to continue to innovate.
Agreed. I stole your break because I was so excited about getting to the second presentation. But we're at the end with wrap up and next steps. Glenn, I see your name here, but what was your comments here?
Well, I just wanted to wrap up our decision, and basically the main decision that was made was that SEOW approved the summer work group for traditional health workers and recommends to PEB and OWEB, the boards, that they move forward with this for the 2024 summer, and that one OWEB board member and one PEB board member be recruited to be on that. Tom also mentioned about getting further information on midwives, and Mercer's going to take that back. There's really no other approvals or decisions we made. I did want to say, kind of a personal note, I wanted to thank both Sue and Tom for serving on SEOW and your work. Tom, a special thanks to you. I mean, your engagement, your knowledge, but you mentioned you've been on there for 8 years, but your leadership on these many issues, from COVID to GLP-1s to even just innovation. I just wanted to provide a personal thanks because I work very closely as a person who staffed SEOW, and just say we'll miss you.
Back.
Thank you, Glenn.
Agreed.
I'll miss all of you too.
All right, anybody with closing remarks? Oh, let me just ask first, Rose, was there any public comment that popped in?
No public comment.
Okay, anybody, floor's open for closing remarks before we end here. Want to thank everybody. Thank Mercer for the presentations and everybody who participated. And I did see all the comments that came in on the chat that were about the discussions being talked. I hope everybody got a lot from today's discussion. I know I did. All right, anybody comments? Going once, twice. All right, we're adjourned. See you all at 1 o'clock.
Bye-bye.